Orthopedic polytrauma defines the catastrophic failure of the body's anatomical containers. The first systemic crisis is the collapse of perfusion gradients inside the rigid fascial compartments of the lower leg, a localized pressure cascade known as compartment syndrome. The second crisis is biochemical. A fractured femur releases marrow into the bloodstream, triggering a toxic wave of lipid breakdown products that travel directly to the pulmonary system. The third crisis is a lethal geometry problem. A fractured pelvic ring expands in internal volume, creating a massive void that allows for unchecked exsanguination. In all three emergencies, standard physical exams produce distracting clinical noise. Waiting for late-stage physical signs to appear actively delays definitive care. To save a polytrauma patient, the clinician must look past the superficial tissue damage and intervene directly at the level of pressure gradients, microvascular chemistry, and retroperitoneal volume. The lower leg's fascial sheath is a rigid cylinder. Traumatic edema fluid cannot expand outward. Limb viability depends on delta P, diastolic blood pressure minus compartment pressure. When delta P drops below 30, outside pressure exceeds inside. Capillary buds collapse, terminating perfusion. This creates a physiological paradox. The myocytes begin undergoing necrosis, even while high-pressure arterial blood continues flowing through the major vessels right past them. This clinical reference image displays the leg discoloration typical of chronic venous insufficiency, a key differential. In contrast, deep vein thrombosis presents with a dull, aching pain and relies on an ultrasound demonstrating the vein's failure to compress. Compartment syndrome is characterized by a specific pathognomic sign, exquisite, excruciating pain triggered by the passive stretch of the ischemic muscle fibers. The pain is radically out of proportion to the visible injury. This is where clinical noise becomes dangerous. A normal capillary refill time and a palpable dorsalis pedis pulse are distractors. Because the thick-walled arteries remain open, these physical signs provide false comfort long after the capillaries have died. This also highlights the biomechanical error of elevating the injured limb. Raising the leg lowers the arterial inflow pressure at the exact moment the limb needs pressure to overcome the compartment gradient. Because arterial pressure is vastly higher than compartment pressure, a palpable pulse tells you nothing about tissue viability. A fasciotomy must be triggered by gradient collapse and passive stretch pain alone. A high-energy fracture exposes viscous intramedullary fat to ruptured venous sinusoids. The fat is drawn into the venous system and propelled toward the heart. The first phase is purely mechanical. These fat globules are pumped into the pulmonary circulation, lodging tightly inside the capillary beds and physically blocking blood flow. As highlighted in this medical excerpt on fatty acid oxidation, the body uses specific enzymes to metabolize lipids. In the lungs, lipase enzymes circulating in the blood locate these lodged fat globules and begin attacking them. This initiates the lethal second phase. The enzymatic breakdown releases free fatty acids that scorch the pulmonary endothelial lining. This lipotoxicity destroys the vessel walls, flooding the alveoli with fluid and simulating acute respiratory distress syndrome, or ARDS. Clinically, this process operates on a delay. There is a deceptive 24 to 72-hour latent period between the initial bone fracture and the onset of systemic failure, as the lipase enzymes do their work. After this latent period, the classic clinical triad emerges: full-blown ARDS, a petechial rash from capillary fragility, and sudden agitation or confusion caused by microinfarcts in the central nervous system. Managing this requires navigating a strict severity-invasiveness matrix. If the patient remains stable with a PaO2 above 80, the objective is early operative stabilization, like intramedullary nailing, to prevent further fat embolization. If the patient becomes unstable, presenting with pulmonary infiltrates and a PaO2 below 60, you hold surgery and initiate high-flow oxygen or BiPAP alongside a corticosteroid trial to blunt the inflammatory response. In critical cases where the patient is comatose with full ARDS, the clinical pivot is entirely towards mechanical ventilation and neurointensive monitoring. Fat embolism syndrome is a delayed biochemical burn inside the lungs. Rushing an unstable patient to the operating room for fracture fixation during peak lipotoxicity will guarantee respiratory failure. We can analyze the pelvis as a closed fluid container. The intact human retroperitoneal space has a baseline capacity of approximately 1.5 liters. This limited volume naturally tamponades the fragile presacral venous plexus, acting as a built-in pressure dressing restricting total blood loss. An antero-posterior compression force alters this geometry. The impact splits the pubic symphysis, snaps the posterior sacroiliac ligaments, and the pelvis hinges outward. By opening the ring, the vault's holding capacity exponentially expands to over 4 liters. With the natural tamponade destroyed, the presacral venous plexus bleeds unchecked into the massive new void. Management hinges on hemodynamic stability. If the patient maintains a mean arterial pressure at or above 65, the protocol directs them to advanced CT imaging to map the vascular damage. If the MAP falls below 65 and the FAST exam shows fluid, the immediate objective is to physically close the vault. The pelvic binder acts as a mechanical compression tool, physically crushing the vault's volume back down toward the 1.5-liter limit. Once the binder is secured and the volume is reduced, the patient must be transported immediately for definitive internal control via interventional angioembolization or preperitoneal packing. An open-book pelvic fracture is a geometry problem. Physically reducing the geometric volume of the container is the only way to stop the patient from bleeding to death internally. We will now run a final validation sequence to test the recognition of these biophysical rules against distracting clinical data. This clinical quiz interface outlines a scenario with built-in distractors. Consider a 19-year-old male, post-intramedullary nailing of the tibia, who presents with warm toes and strong 2+ pulses, but extreme unrelenting pain specifically upon passive extension of his great toe. The warm toes and strong arterial pulses are step 2 noise that must be ignored. While the thick-walled arteries are still pulsing, the microvascular gradient has already collapsed. The exquisite pain on passive stretch confirms the ischemia. The diagnosis is acute compartment syndrome, and the definitive action is an immediate fasciotomy. Looking at this assessment interface, we can evaluate a complex multi-organ timeline. A 24-year-old female, 48 hours post-motor vehicle collision, with bilateral femur fractures, develops sudden agitation, tachypnea, and a pinpoint petechial rash on her axillae. The 48-hour delay matches the latent lipotoxic phase of fat embolism syndrome. The circulating lipase enzymes have begun scorching the pulmonary endothelium. She is entering ARDS. You must delay any further surgical fixation of the femurs and immediately execute supportive mechanical ventilation protocols. Surviving catastrophic orthopedic trauma depends on managing invisible biophysics, pressure gradients, biochemical toxicity, and compartmental volumes before the physical exam catches up to the pathology.